Welcome to LPN LaunchPad's review of the genitourinary system assessment. Let's begin by providing an overview of how the nurse systematically evaluates urinary and reproductive functions to detect potential disorders. The interview phase becomes crucial for gathering details about urinary patterns, dysuria, urine characteristics, incontinence, and pain, all of which guide accurate diagnosis. Next, it helps to examine urinary patterns by asking how frequently the patient urinates, whether there are nighttime awakenings, and whether any patient has noticed any recent changes in routine. Continuing with the theme of urinary patterns, the nurse then explores urgency and flow, inquiring about sudden urges, difficulty starting the stream, or the need to strain during urination. The interview should cover urine volume and findings, such as whether the patient empties the bladder or experiences dribbling, with normal expectations of around 4 to 7 voids daily and minimal nocturia. It is also essential to connect these observations to common NCLEX tips, recognizing frequent urination, plus excessive thirst, as suggestive of diabetes, and hesitancy with a weak stream in older males, as indicative of benign prostatic hyperplasia. The dysuria assessment targets pain related issues by asking if there is burning, discomfort, or pain during urination, clarifying the nature of the sensation, and any associated symptoms like fever or chills. Since normal urination does not involve discomfort, dysuria can indicate infections, bladder stones, inflammation, or other conditions that require closer investigation. The nurse should also inquire about urine characteristics, such as color, odor, and clarity, prompting questions about whether the urine is unusually dark or light, has a strong or foul odor, or appears cloudy or bloody. Linking these findings to specific conditions, cola-colored urine with edema might suggest glomerulonephritis, pink or red urine without pain could indicate bladder cancer, and cloudy, foul-smelling urine often signals infection. For the NCLEX, cola-colored urine plus edema aligns with glomerulonephritis, pink or red urine in the absence of pain raises suspicion of bladder cancer, and cloudy urine with foul odor commonly points to a urinary tract infection. Transitioning to urinary incontinence, the nurse explores whether leakage occurs, under what circumstances, and whether it's triggered by coughing or sneezing, stress, sudden urges, urge, or continuous dribbling, overflow. Under normal circumstances, there should be no leakage. Stress incontinence may result from weak pelvic floor muscles. Urge incontinence could stem from an overactive bladder, and overflow incontinence suggests incomplete emptying. Bringing in some NCLEX specific reminders, older men may present with dribbling linked to benign prostatic hyperplasia. Postmenopausal women can show stress incontinence, and neurological conditions might be associated with overflow incontinence. Shifting to pain assessment, the nurse checks for flank or suprapubic discomfort. This can uncover underlying concerns such as kidney stones, pyelonephritis, or bladder infections, each of which requires targeted interventions. Since no pain is considered normal, flank tenderness might indicate renal issues. In contrast, suprapubic pain can signal bladder infections, cystitis, or urinary retention, highlighting the importance of pinpointing the exact location. As a summary of these interview points, it is helpful to remember how abnormal patterns in urination, pain, or leakage might reveal urinary tract infections, diabetes, benign prostatic hyperplasia, kidney stones, or other bladder dysfunctions. Moving on to the inspection stage, the nurse visually examines external genitalia and the urinary meatus for infection, trauma, or systemic disease, maintaining a respectful approach for both male and female patients. Beginning with male genitalia, the nurse ensures privacy and adequate lighting to check the penis for lesions, ulcers, discharge, or skin changes, retracting the foreskin, if present, to assess for issues like balanitis or phimosis. The scrotum is also evaluated for symmetry, swelling, discoloration, or lumps during the male inspection. Continue checking the urethral meatus for discharge, erythema, or narrowing that could indicate an underlying problem. Shifting the focus to female patients, the nurse positions the individual comfortably, often in lithotomy or supine with knees bent, and inspects the labia and vaginal introitus for redness, swelling, lesions, or abnormal discharge. Further exploration of the female external genitalia includes examining the clitoris and perineum for growths or scarring and assessing any discharge for color, consistency, and odor to clarify whether it falls within normal limits. Connecting these observations to NCLEX concepts, painless genital ulcers often suggest syphilis, painful vesicles usually indicate herpes, and thick yellow green discharge typically points to a sexually transmitted infection. Next, the urinary meatus is inspected. This procedure aims to detect infection, inflammation, or structural problems by gently separating the labia in females or retracting the foreskin in males, noting any redness, swelling, or discharge. Recognizing normal meatal findings as clean and pink with no discharge is essential. In contrast, erythema, unusual discharge, or meatal stenosis may suggest infections like gonorrhea or chlamydia, or even trauma related complications. Reiterating relevant NCLEX tips here, painless genital ulcers are a hallmark of primary syphilis, painful vesicles often signal herpes, and thick, yellow green discharge raises suspicion for various sexually transmitted infections. Summarizing inspection steps, the nurse should examine male and female genitalia separately, verify that the urinary meatus is free from inflammation and discharge, and remain alert to lesions, swelling, or discharge that can indicate infection or trauma. Moving next to the palpation phase, the nurse uses touch to evaluate the bladder and flank regions further, searching for signs of urinary retention, tenderness, or kidney issues. The good nurse will use cues found during the interview and inspection while performing the palpation phase. When palpating the bladder, placing the patient supine with knees slightly bent and pressing gently just above the pubic symphysis can reveal a distended bladder or elicit discomfort, both of which merit closer review. Typically, an empty bladder is not palpable and causes no pain. However, a firm, round mass could mean urinary retention, and tenderness might suggest cystitis or other inflammation that requires prompt attention. Incorporating NCLEX insights, suprapubic pain with frequent voiding patterns may point toward cystitis. A distended bladder in someone who has not voided is a strong indication of retention, commonly seen postoperatively. Turning to costovertebral angle, CVA, tenderness, the nurse locates the area between the lower ribs and spine, lightly strikes it with the ulnar edge of the hand, and notes any pain that might suggest kidney stones or infection. Finding no pain on percussion is normal, whereas tenderness may signal pyelonephritis, renal calculi, or hydronephrosis, prompting more focused tests and interventions. NCLEX frequently addresses CVA tenderness, especially when combined with fever and dysuria, which indicate pyelonephritis. Severe flank pain hints at renal calculi, or isolated tenderness that might be musculoskeletal rather than renal. Consider a practice question. A patient reports increased urinary frequency and nocturia. Which combination of findings would most likely suggest a diagnosis of diabetes? A. Frequent urination with excessive thirst. B. Frequent urination with painful burning. C. Urinary hesitancy with weak stream. D. Urinary incontinence with dribbling. The correct answer is A. Frequent urination with excessive thirst, which aligns with the classic presentation of diabetes involving polyuria and polydipsia, whereas the other choices suggest infection or prostate related issues. Here's another practice question. A male patient has a painless ulcer on the penis during genital inspection. Which condition is most strongly indicated by this finding? A. Genital herpes. B. Primary syphilis. C. gonorrhea, D. chlamydia. The correct diagnosis is B. primary syphilis, because the hallmark painless chancre distinguishes it from conditions like genital herpes, which typically cause painful lesions. Consider this scenario for the final practice question. A postoperative patient is found to have a firm, rounded mass in the suprapubic region and has not voided. What is the most likely explanation? A. Bladder infection. B. Urinary retention. C. Normal bladder fullness. D. Overactive bladder. The correct answer is B. Urinary retention, a firm distended bladder in a patient who is unable to void points to urinary retention, a common postoperative issue that requires intervention to prevent complications. Hey there, this is Brian, the creator of LPN LaunchPad. I aim to give every student a fair review for the NCLEX for free using YouTube videos that can be watched or listened to without losing value. It may be free, but it is still valuable. If you find these reviews helpful, help me keep this project alive by hitting the like and subscribe buttons and continuing to watch my videos. Also, check out the free ChatGPT NCLEX review quizzes I have made to accompany these videos. A link is in the description or search for LPN LaunchPad in the Explore GPT box. This review has been an LPN LaunchPad production. We care for our future nurses by freely sharing knowledge.